Hi guys, it's Tamara. I'm back with another video. Let's go ahead and close out our Friday by talking about the history and the development of the DSM. Thank you so much for being back with me, guys, for those of you who are already subscribed. And I ask that those of you who are new, go ahead and hit that subscribe button over there. That way you can stick around with me while we talk about mental health. This is an educational channel and a counseling channel where I talk about all things psychotherapy, hence the title of this channel, which is Anchored in Knowledge. Thank you so much for being with me. The benefits for you today in this video is that you're going to learn about the history of the DSM. We're also going to talk a little bit about some of the barriers of the DSM. I'm not going to dig in too deep, guys, but I will leave some resources in the description box below. That way you can go back and check on some of that information. You can also do some fact checking if you want, some fact checking. And you might also be able to type into YouTube history of the DSM and pull up some history to kind of help you understand the DSM a little bit better. So let's just go ahead and jump in, guys. I want to talk just a little bit about the interesting history of the DSM. It really is an interesting history. But first, let me define some things for you. So there are three important things that I want you to keep in mind in this video, and I'm going to put them over here for you. One is the associations that have some kind of influence over the DSM, and there are definitely three. There's one main one, but there is three as well. So the first and the main one is the American Psychological Association. The American Psychiatric Association. I apologize for that because there's two. The American Psychiatric Association, I'm going to put over here. That is the association that has direct control over the DSM. Okay, and the DSM is the Diagnostic and Statistical Manual of Mental Disorders. The Diagnostic and Statistical Manual of Mental Disorders. The American Psychiatric Association is the main developer of the DSM. Now, there's another association that has some influence over it as well, and they are the American Psychological Association. And there's another association specifically for counselors, and that is the American Counseling Association. Three of these agencies, right over here, guys, have had some direct influence over the DSM. Now, there are a variety of other associations that have developed over the years, but these are the three main ones that I tend to get my information from, and so do a lot of other mental health professionals. Okay, so that is the associations that have some direct influence over the DSM. That is the name of the Diagnostic and Statistical Manual of Mental Disorders, the DSM. And the third thing that I want you to keep in mind is another diagnostic manual, and that's the ICD, okay, the International Classification of Disorders. Okay, so I want you to keep those three things in mind, and if I have to put them back over on this side for you, I will, to kind of help you go along. But let's just go ahead and jump into the discussion of the DSM and how it's come about. So I have my notes here, as I always do, to kind of help me stay on track, and I welcome all of your questions and your comments and experiences on this topic. So you're probably wondering why the DSM was ever invented in the first place. Well, the DSM was created to classify mental health conditions that providers found difficult to discuss unless there was some kind of classification of what was being discussed. So example, picture this with me. You are a psychologist and you're trying to reach out to another psychologist about a mutual patient. You want to coordinate care and get some background from that doctor, and the doctor may want to get some background from you. The thing that's going to confuse the both of you is if there is absolutely no classification of the mental or behavioral health condition that you're talking about. You could be talking about depression, you could be talking about anxiety, you could be talking about psychosis, but the other psychologists may not know that. If you can't label the behavior, if you can't label the psychological condition. So in order to create this common language between two providers, a psychologist has to be able to label something and classify it, right? When I talk to my colleagues or other providers who have referred patients or clients to me, I often make reference to the label, for example. So I'll say, my client has depression, recurrent episodes that is moderate, right? Or I'll say, this patient is really showing characteristics of schizophrenia. They are meeting criteria for delusions and hallucinations, but I think these delusions and hallucinations are acute, right? So that's a little bit of the lingo. And I do drop lingo on this channel as well so that you can get used to it. But that's the lingo. And in order to understand a particular patient or client, we have to have the language. And that's what the DSM was created to do. The ICD, the International Classification of Mental Disorders or Disorders, was also designed for that purpose. Now, the other purpose for the DSM is to keep everything medical. Right? We're not talking about some phenomenon that's, this interesting, what's the word I'm looking for? This interesting, vague thing that's happening. We don't want that in the field. We want to make mental health as medical as we can, because just like heart disease, just like heart attacks, mental health conditions also need to be treated in the same way, right? We need to treat it with medication. We need to treat it with follow-up appointments. We need to treat it with specialists and a variety of professionals that can help this person get better. So that was the other purpose of the DSM, to create a medical model of mental health disorders. Now, the other thing too, the DSM and the ICD was also created to bill insurance, right? We have to be able to say to insurance, hey, look, this is what the patient has. This is what I'm treating the patient with. And this is the goal for conclusion of psychotherapy or for psychiatric counseling or following, right? So you have to bill insurance. That's part of it. And the last thing I want you to think about in terms of why the DSM was created was to create a free-flowing system, right? We have to create a system where language is mutual, language is well understood, to keep things flowing on a smooth level. If we don't have the lingo and we can't collaborate as professionals, then a patient's care is going to be extraordinarily perplexing, right? So we have to be able to have this free-flowing discussion of mental health disorders. Okay, so let's keep moving. So what is wrong with the DSM? Well, the DSM, it has had a huge history, and I want to go over this with you. All right, so we're going to talk about the DSM, the various numbers and categorizations. Okay, the DSM-1 was created in 1952, and it was kind of like an introduction to mental health, right? It was created to begin to foster this medical model. It was created to begin to create this free flow system where professionals could communicate. In 1968, the DSM-2 was created. It was kind of like an updated version. In 1974, the DSM-2 removed homosexuality as a mental health categorization. One of the reasons why was because of social pressure and political pressure. We had absolutely no research on homosexuality. We also had no clear understanding of why it happened. We also lacked the ability to treat it, to study it, to make sense out of it. In 1974, there was a group of professionals who had met to update the DSM, and there were a group of gay activists, gay rights activists, who had stormed into the conference of the professionals that had been there discussing the DSM. And, they basically threatened the American Psychiatric Association, okay? They weren't peaceful. They were like, if you don't stop categorizing us as sick and pathological, we're going to bring you down politically. And that was a threat. And the American Psychiatric Association just kind of was like, okay, homosexuality is going to be taken out of the DSM. So in 1974, it was removed, and it was removed because of the political and social pressure. All right. The DSM-3 was created, and there were a lot of inconsistencies in diagnostic criteria. So they tried to revise it in 1987. Then in 1994, they revised it to the DSM-4. It had been a 6-year effort to refurbish and recreate the DSM. There was a lot of inconsistencies and nothing really made sense. It was hard to categorize things. Homosexuality was removed from the DSM, a year or two before that. 6 years before that. And so it was like everybody that had some influence over the DSM was trying to like move things around and fix things and put things correctly in its place. So the whole goal was to kind of increase congruence, right? We want to make sure that everything is congruent and consistent. All right. So then after 1994, the DSM-4 text revision was created, and that was like the revised version of the DSM-4, and it included a lot of psychiatric conditions. However, we still lacked research. We still lacked the necessary information to make sure that there were no consistencies. So in order to kind of organize things and create more consistency and create a more clear message, we developed the DSM-5, and the DSM-5 had started in 2000, right? That's when the work started. It was published 13 years later in 2013. And the whole idea was to, make sure that we're not over-diagnosing, to create different categories, to create umbrella categories, right? There's no longer these really limited boxes we put people in. There's now, everything is kind of like on a spectrum, right? So autism spectrum disorders, we don't have like severe autism, mild autism, moderate autism, Asperger's. We have, we don't have those categories because human beings are very fluid, right? They change, they grow, things, life causes things to get moved around, temperaments change, attitudes change. So now we have diagnosis on a spectrum, and you're mild, moderate, severe, or somewhere in between. And that's how we providers began to categorize mental illness in 2013 when the DSM-5 came out. Now, I want you to keep two things in mind, that the DSM is very reflective of the zeitgeist. It's reflective, I should say, of the spirit of the times, right? It depends on how the world at our current standing is viewing things that determines what the DSM is going to look like. All right. So there's a lot of political and social pressure riding on the shoulders of the DSM. I also want you to keep in mind that the DSM is reflective of the social and political structure at the time. In 1974, homosexuality was removed from the DSM because of political and social pressure. We had no research. So here we are in, 2019, and we got the DSM-5, and there's still some controversy because we have a spectrum, but everybody's getting placed in categories that may or may not be healthy or may or may not be true. For example, instead of putting them in the box of bipolar disorder, we put them under a category of dysregulated mood disorder. And unfortunately, a lot of kids get put up under that category when they start to show signs of bipolar disorder. The scary part is that a lot of kids are being diagnosed with DMDD, and that is not a good thing. So there's a lot of hiccups with the DSM-5 already, and sadly, when it was published, there were a lot of inconsistencies, incongruence, information that was incongruent with research. There was also spelling and typographical errors, guys. I know we're human, we all make mistakes, but not in the DSM. Like, it should have been revised and reviewed. So, basically what all of this means is two things. We're human, and we typically diagnose based on political and social pressure. We try to find research to support theories that are in the DSM, but sometimes that's really hard, and some of the research is really wacky when it comes to the DSM. And so here we are trying to figure out as a nation, how do we categorize mental illness correctly, and really does our system work? If you ask me personally, does the DSM make sense? I say absolutely not. It's really better to diagnose a person based on what you're seeing in them, based on character and based on background information. I'm going to post a link to my video that I did on Monday about the DSM, and I think that's important for you to watch because I talk a little bit about how we diagnose. We really do, those of us who are good practitioners, we really do try to stay out from the DSM and try to see you as a person. Thank you guys for being with me in this video. I encourage you to give it a thumbs up if it was helpful to you. We are so way over time. We are 5 minutes over our video time. We're going to try it next week once again. Hopefully we can make it to like 9 minutes or 10 minutes. I wanted to make sure, however, that you got comprehensiveness in this video. I encourage you to go ahead and hit the subscribe button if you'd like to stick around and keep discussing these topics, guys. But in the meantime, I wish you well, and I will see you